All right, we're at just about 5 past the hour, so I'm going to go ahead and get started. Thank you all for joining us this evening. It is so great to virtually see all of you here and all of these intros happening in the chat. For those of you who don't know me, my name is Megan Bernstein. I am Marlborough's Alumni Engagement Manager, and I'm so excited to welcome you to our 4th ever Aiming High event this evening. Tonight's event features 2 of our fellow alumni, and I am so grateful that they are here with us and taking the time to share themselves and their expertise with all of us. I know that they have a lot to talk about and a very educational talk prepared for us. But we should also have some time for Q&A at the end. So please feel free to put those questions in the Q&A box, which you can find just at the very bottom of your Zoom screen. It's a little icon that literally says Q&A. So just click in there and go ahead and type any questions that you have. I will be here throughout the evening monitoring the chat for any tech or logistical issues. And also I will help moderate the question and answer portion for our speakers. So I think that takes care of all the virtual housekeeping. So it is now my pleasure to formally introduce our speakers. Dr. Bath, Dr. Eraka Bath from the Marlborough class of 1989 is a child, adolescent, and forensic psychiatrist who is an associate professor in the Division of Child and Adolescent Psychiatry and the vice chair for Justice, Equity, Diversity, and Inclusion at the UCLA Neuropsychiatric Institute in the David Geffen School of Medicine. She has a long-standing interest in healthcare disparities, minority and community mental health, with particular interest in the underserved populations of foster care and juvenile justice involved youth. Dr. Bath specializes in diagnostic assessment and forensic consultation with adolescents with an emphasis on high-risk youth, including those with histories of trauma, juvenile delinquency, and foster care placement. Her research focuses on systems-involved population in the juvenile justice and child welfare systems, and she also maintains a private practice focused on forensic consultation to attorneys and governmental agencies on a variety of cases involving mental health and the law, including juvenile competency to stand trial, commercially sexually exploited youth, fitness and waiver to adult court, personal injury, PTSD, child maltreatment, education rights, risk management, termination of parental rights, and child custody matters. And in addition to all of this incredible work, it has personally been such a joy to get to know Eraka and work with her through her service on Marlborough's Alumni Council and now as a Marlborough mom herself. And we also are so delighted to be joined by Lily Roh. She is the director of the Office of Population Health and Accountable Care at UCLA Health. In her role, Lily aims to make healthcare as affordable and of highest quality possible for UCLA Health's patient population. Her team of program managers, programmers, and clinical staff manages the financial and quality performance on UCLA Health's alternative payment model contracts by improving care across the care continuum. Prior to her role in population health management, Lily worked in hospital administration, in hospital operations, finance, and quality improvement. She received a Bachelor of Science from Cornell University and a Master in Public Health from Yale University, and of course is a member of the Marlborough class of 2007. Like I said, I am so grateful to have you both here. And without further ado, I will turn it over to you.
Thank you, Megan, for that great introduction. And I'm thrilled to be here with Lily, fellow Bruin. Okay, so tonight we're going to talk about racism as a public health issue and explore it through 2020's, the gift that keeps giving lens from COVID-19 to health and police brutality. My disclosures and potential conflicts of interest are really my own personal biases based on my life experiences. And really, the president of the American Psychological Association, Dr. Sandra Schulman, really stated it well, that we are living in a racism pandemic. It's taking a heavy psychological toll on our African American citizens and others. The health consequences are dire, and racism is really associated with a host of debilitating conditions, including post-traumatic stress disorder, substance use disorders. And the stress caused by racism can also contribute to the development of other physical diseases. The statement, "I can't breathe," is as relevant for COVID-19 as it is for the police violence against Black people that aggravated the spring of 2020. The color of COVID should not be a surprise if we begin to understand and unpack systemic racism, which is a public health issue. Let's take 4 case studies that were profiled in a recent LA Times article. Gary Fowler is a 56-year-old Black man who was denied COVID-19 testing and hospital admission by 3 Detroit emergency rooms where he complained of difficulty breathing. Then there's Deshaun Taylor, a 23-year-old Black man who was sent home twice from a Chicago hospital even after testing positive from the virus. Reginald Ralph was a 50-year-old Black man who was turned away from an urgent care clinic in suburban Chicago without being tested in spite of his labored breathing, fever, and cough. And lastly, Kimora Lynham, a 9-year-old Black girl with a fever of 103 degrees, was sent home from a Florida academic medical center without being tested for COVID. They all died soon after. It took another Black woman with respiratory symptoms 3 attempts until she was admitted to the hospital. 10 days later, when she was being discharged, she had to fight with the doctors over her care, pushing them to order home oxygen service because her blood oxygen saturation level was in the 80% range, well below the normal 95% or higher. Less than 90% indicates a need for medical attention. So why does this matter? Black and Indigenous Americans continue to experience the highest actual COVID-19 mortality or death rates nationwide, more than 3 times the rate of whites and Asians who have the lowest actual rates. And these disparities are the result of overarching, all-consuming, omnipresent pandemic of racism that is at the root of negative COVID-19 outcomes across communities of color. Racism causes structural inequities and results in negative public health effects. Racism accounts for the poorer outcomes after acquiring COVID-19, limited access to testing, higher presence of underlying health conditions like diabetes, hypertension, obesity, and asthma, and receiving delayed or poorer medical care due to lack of insurance and provider bias. The term systemic racism really refers to a system in which public policies, institutional practices, cultural representations all reinforce ways to perpetuate racial group inequity. And this reflects how historically accumulated white privilege and national values preserve the gaps between white Americans and Americans of color. Structural racism refers to the differential access to goods, services, and opportunities by race. The physical and structural environment in which humans grow, learn, work, and play shapes intergenerational population health. It's food deserts and zip codes determining health outcomes. Remember, poverty is structured, and so is privilege and economic advantage. Taken another way, think about how laws, policies, belief systems, and practices operate and overlap to perpetuate inequities. It's as ubiquitous as the air we breathe for those allowed to breathe. And it's important to know that race is really a modern idea. It is not based on biological or scientific fact. And race and American freedom were born together. Race as a political construction, which has shifted over time. Remember, our DNA is 99.9% the same as the person sitting next to us. No one was white before he or she came to America, and it took generations and a vast amount of coercion before this became a white country. In 1899, if we think about the sort of striking and shifting race timelines, 1899, Southern and Eastern European immigrants were considered not quite white. Or in the early 1900s, courts decided who was white by petition. In the 1930s, Mexicans changed to non-white to limit immigration. But in 1942, Mexicans were switched back to white to increase workforce in the context of World War II. And post-World War II, certain Europeans were accepted as white as they became prosperous. Or as Toni Morrison says, there's no such thing as race, there's just the human race. So when we think about disparities, we need to move away from individual blamings and perceptions of moral failings due to supposed poor choices. We need to think more structurally. And let's take something like diabetes. We're blaming someone because we're thinking they're making, bad food choices and eating junk food and fast food every day. My colleague, Dr. Ruth Shim, had a great anecdote to speak about this sort of bias. And it really happens also at the physician level, where we'll have bias and be frustrated with patients because they're making bad choices. So, everybody needs to eat more carrots and broccoli, but if I'm making less than $15 an hour and I have to choose between buying a bag of broccoli and carrots or a hamburger that's $1, the hamburger is actually going to provide more calorie dense nutrients. So yes, choice does matter, but choices are structured. And so health inequities arise when certain populations are made vulnerable to illness or disease processes through an equitable distribution of protections and supports. So pre-existing conditions and those that confer additional vulnerability to COVID-19 are exacerbated by structural racism. The racial disparities that we're seeing in COVID-19 mortality are due to these compounding elevated risks from our systems of housing, labor force, healthcare, and policy responses, all a result of systemic racism. So racism accounts for the poor outcomes after people acquire COVID-19, limited access to testing, and then higher prevalence of underlying health conditions, which we know are related to geography, housing access, and employment. I want to give you some examples of how this plays out that are pretty COVID specific, because we could talk, we could have a whole day or several on racism and its impacts on health. But let's talk about a few examples. So hand washing. We say that hand washing is the cheapest and one of the most reliable ways to mitigate illness and risk of infection. Yet it is race that is the strongest predictor of water and sanitation access. African American and Latino populations are 2 times as likely to lack access to clean water in their homes, and Native Americans are 19 times more likely to access clean water. Social distancing as a privilege. This Charles Blow in the New York Times had a great op-ed about this. But social distancing is a privilege. It is easier to do when you have resources, stable housing, and housing that's spacious. We know that Black and Brown communities are more likely to be living in denser housing, crowded and multi-generational households, and therefore more likely to fall ill than those who live alone or in small families. Residential segregation drives Black families disproportionate exposure to neighborhoods where there are higher pollutants and environmental toxicities. These realities also mean that zip codes are also food deserts and suffer from underperforming schools, neighborhood blight, and disinvestment. There are no Trader Joe's and Whole Foods in these neighborhoods. Another example is the digital divide. It's not only about kids not having access to appropriate technology like iPads and laptops, which there are gaps in that as well, but it's also about not having enough connectivity and bandwidth to adequately log on and learn, or quiet and private space to Zoom and learn. Adult digital divide realities converge in a strikingly similar pattern along class lines. There are stark differences in being able to get a paycheck and benefits while working from the comfort of one's home versus jobs that are dependent on being in person and thus at higher risk for exposure. So I'm talking to you if your biggest worry today was your Zoom background or lighting, pay attention. Being essential but expendable. Economic realities have historically been structured and are such that people of color are in environments where they have a higher likelihood of contracting the virus, such as greater workplace exposures, including the inability to work from home or no access to sick days, living in geographic areas, housing arrangements, including congregate settings like treatment centers, correctional facilities, or group homes, or accessing public transportation where the virus is more easily spread. So we have a situation where Black and Brown people are considered essential but expendable due to being disproportionately overrepresented on the front lines of low wage and in-person jobs that place them at higher risk for getting sick and more risk of poor compensation. So I ask you to think about who has to take public transportation to get to work, who's working in public transportation, who has to work in a post office, grocery store, meat packing facility, and who is cleaning houses. Mental health gaps in treatment need and receipt. Black and Latinos with mental health and substance use disorder are more likely to be incarcerated and homeless than the general population, placing them at increased risk for COVID-19. Homeless and incarcerated individuals have extreme challenges following CDC guidelines for social distancing, washing hands, self-quarantining. Incarcerated individuals re-entering the community without adequate treatment, supports, and services may also be at higher risk for COVID-19. So we really need strategies to prevent disruption of substance use and mental health services, to increase capacity for telehealth and support individuals with substance use disorders and serious mental health conditions, particularly in these under-resourced communities. The economic fallout from this pandemic has hit Black and Latino families the hardest. In one study, more than 60% of households with children in the US reported serious financial problems. This includes struggles to afford medical care, depletion of household savings, and difficulty paying credit card and other debts during the coronavirus pandemic, according to a poll. However, Black and Latino households with children really bear the brunt of the hardship. And one study showed that 86% of Latino families reported these difficulties and 66% of Black households reported them. The Black-white wealth gap further exacerbates these risks of the economic fallout because there's little to no safety net. The wealth gap means that for every dollar of wealth that a white family has, a Black family has a penny and a Latino family has 3 pennies. Put another way, white family wealth was 7 times greater than Black family wealth and 5 times greater than Hispanic family wealth in 2016. Despite some fluctuations over the past decades, this disparity is as high or higher than it was in 1963. Racism costs everybody. It's expensive and everybody pays and everyone is taxed. A study done by the Citigroup found that $16 trillion has been lost over by GDP over the last 20 years, noting 4 key racial gaps between African Americans and whites. 13 trillion lost in potential business revenue because of discriminatory lending to African American entrepreneurs, with an additional 6.1 million jobs not generated as a result. 2.7 trillion in income lost in disparities in wages suffered by African Americans. 218 billion over the past 2 decades because of discrimination in providing housing credit, and 90 to 113 billion in lifetime income lost in discrimination and accessing higher education. So lastly, if we want to talk about COVID-19, we need to talk about police brutality. Police violence and state-sponsored terror is part of the forceful muscle in the public health crisis of racism and has been part of our nation's backdrop and blueprint since its founding. Roughly 1 in 1,000 Black males can expect to be killed in their lifetime by the police. This is now close to the same rate that we are saying Black Americans die of COVID, which was 1 in 1,000 in October. And I just checked the APM statistic is now it's 1 in 875. The punishing reach of racism is operative really from womb to tomb. And we see that there's really no sanctuary for Black bodies, whether they're bird watching like Christian Cooper, sleeping in one's bed like Breonna Taylor, or jogging while Black Ahmaud Arbery, or in hospitals like little Kimora Lynham. Sorry, I have a ghost in my slides. So the police brutality is a potent social determinant of health and needs to be thought of that way. And the, negative health outcomes are not just, being shot at or beat up by police, right? But it's also the adverse physiological and psychological responses that increase morbidity and vulnerability. It's the arrests, incarcerations, and bills that cause financial strain on families. It's racist public reactions that create stress. And so the cycle of harm from police brutality is beyond just the person who is dying. It affects families and communities. And just one thing to, give a mini shout out about epigenetics. These effects are passed on. The negative effects of racism is actually passed on intergenerationally. And so in one study, the anticipated negative police youth encounters that pregnant, expectant Black American women felt really increased their stress. And so they had this sort of increased anticipatory anxiety related to being worried about raising children while Black. So what can we do? Racism is an American problem, and the work to do is not really work. It's about learning history and learning both Black American history, Indigenous American history, and not just white supremacy informed American history, which is most commonly taught in America, and really to be reflective and remember to ask ourselves, is there justice and equity at play? And if not, why not? And what is my role, right? So Americans with awareness of racism, we must be, intentional about keeping conversations going and not ostracize peers, but educate them to be, in dialogue. And recognize, saying things like, I don't see color, please do. Please see everyone as they are, but judge them on the content of their character. And then you're starting to practice anti-racism. Recognize saying things like that might be indicate that you're looking through a lens of more subtle white supremacy narratives. Some people are like, what do you mean white privilege? I worked hard. Yes, but there are a lot of people who don't work hard and do very well, and a lot of people who work very hard and get nowhere. And so many work hard, but we all have different levels of privilege. And the number one founding principle of inequity and disadvantages in America is anti-Blackness. This permeates every system. And so white privilege is really not having the additional burden of being Black in America, and will end once structural racism ends. So until then, ask, am I using my privilege to advance equity and justice? Dr. Kamara Jones, who is a preeminent scholar of race, really asks people to just always reflect, and that's really part of the anti-racist practice, and consider, how is racism acting here, and think about structures, policies, practices, values, the unwritten how, and the why. And then in terms of, the way forward, like individual efforts, learn about historical events, ideologies, and really be reflective. Run DMC says check, or I think it's Public Enemy, check yourself before you wreck yourself. Analyze concepts and reflect on your own racial identity, bias, and privilege. Some of my students at UCLA now want everyone to show a positionality statement before, and it's reflecting on one's own privilege based on, who they are, and really reflect on ways that you can integrate anti-racist work into everyday lives, and recognize that anti-racism and anti-white supremacy is not anti-white people. It's against the pseudo-scientific ideologies that white people are genetically superior to those of other races. And so these are just acknowledgements to my mentoring team and some of my collaborators at UCLA. And thank you very much. And Lily, do I stop share or you're going to share your own?
Yes, I will share my screen here. Okay, can you guys see my screen? Okay, perfect. Thank you all for having me on today on this extremely important topic. And thank you, Dr. Bath. I certainly learned a lot during your talk here. And a special shout out to Marlborough class of 2007. Really love the support that you guys have shown today. And I think you guys are all peers and mentors in this collective learning process, bringing us here today. So before we start, I just wanted to start by defining public health and what it means. So one classic definition is by C.A. Winslow in 1920 that states that public health is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public and private communities, and individuals. And when it comes to public health outcomes, really we're looking at three things: life expectancy, which is also known as mortality, quality of life, and disease burden, also known as morbidity. To effectively achieve public health's core mission of preventing disease, prolonging life, and promoting health, health equity is absolutely required and fundamental. Health equity is achieved when all individuals have fair and just opportunities to achieve optimal health outcomes. And unfortunately, systemic racism has created those unfair and unjust obstacles to achieve health equity and public health outcomes across society, organizations, public and private communities, and individuals. And Dr. Bath did a really great job of outlining social determinants of health and how police brutality is certainly an absolute component to that. And we know that health inequities and disparities are symptoms of broader social and economic inequities rooted in systemic racism and its resulting barriers across social determinants of health. Though healthcare is essential to health and health outcomes, research has shown that is alone a relatively weak health determinant, and the broader social determinants of health have a larger impact on overall outcomes. Social determinants of health are the societal structures in which people live, work, and age in, and they're typically bucketed into these 5 categories: economic or financial stability, education, social and community context, neighborhood and the physical or built environment, like, for example, access to healthy foods, and access to healthcare services. And we know that all of these social determinants of health are deeply rooted in systemic racism. Though there's growing research outlining the importance of social determinants of health, addressing all of these requires an all-hands, all-sector approach. The multiple cities, including Los Angeles, has declared systemic racism as a public health crisis. Public and private sectors need to work together and align efforts against systemic racism, particularly as it relates to healthcare access and affordability. So Dr. Bath had outlined as well diabetes as one example that it absolutely has been disproportionately affecting racial and ethnic minority populations. When we just look at the prevalence rates and compare that to non-Hispanic white adults, the risk of having diabetes is 77% higher in Black and African American adults, 66% higher in Hispanic and Latinx communities, and 18% higher in Asian Americans. Racial and ethnic minority adults are also less likely to receive recommended routine care to effectively manage their diabetes due to disparities in social determinants of health. When you look at the out-of-pocket expenditures for a patient with diabetes versus those without, it's about double. So you can imagine how quickly bills and for seeing our providers, paying for medications adds up, and how challenging it is to afford routine care and coordinate transportation to and from appointments across multiple providers, ophthalmology for your annual eye exam, for your primary care doctor, endocrinologist, getting to get your labs checked, going to the pharmacy to pick up your prescriptions on an ongoing basis. And very often routine care is deferred or forgotten. And we know that uncontrolled and unmanaged diabetes results in other complications longer term, like kidney and heart disease. COVID-19 is absolutely perpetuated that. So I know locally at UCLA, we have been looking at deferred care related to diabetes, and we're terrified of what that means long-term when it comes to long-term health complications for uncontrolled chronic disease and preventive health in diabetes management, such as other, comorbidities that will likely occur later in life. And so those various groups have made efforts to resource, diabetes management and education programs. Unfortunately, they are seeing lower enrollment rates in racial and ethnic minority populations. And part of that is because of the lack of cultural competency and community engagement in disease management and education. And it really needs to be at the forefront in any new program development to have any hope in making strides in health disparity reduction. Another case example is maternal mortality. It's a good example of how public health success, and any success, especially in public health, it is dependent on how you measure it. So, this is both a success story and a failure when it comes to reducing health disparities. And so in response to the increasing rates of maternal mortality in the state of California and at the national level, there are a number of public and private entities that partnered together to create in California something called the California Maternal Quality Care Collaborative, or CMQCC. And currently there are over 200 health systems, including UCLA, that participate in CMQCC. It's been great to put together sort of across all these amazing thought leaders, evidence-based quality improvement toolkits, safety protocols, sharing data so that we know how we're doing and can track progress collectively as a state. And now the CMQCC maternal database represents about 95% of all births. However, when you look at maternal rates over time, it looks like a great public health success story, right? You can see a drastic reduction in maternal mortality over time. However, if you look specifically at health disparities, same snapshot between 2000 and 2003, you see that health disparities in maternal mortality have actually worsened from 3.5 times higher to 3.5 times higher in Black and African American women versus non-Hispanic white women. So again, really the success depends on how you measure it moving forward. And so a lot of examples like this one with CMQCC, it shows that a rising tide through improving patient care over a broad, all patient population base may raise all boats, but it certainly will have zero impact on any improvements towards racial justice. So in my role, I have a pretty broad overview over regulatory and performance-based programs that we're required to report on, perform well on, and no programs that I know of have had any incentives tied to health disparity reduction and racial justice. One state program tried to do that, called PRIME, where we had to have an action plan targeted around disparity reduction, but we actually were reimbursed just by having the plan alone. No, targeted improvements towards, for example, blood pressure control in African Americans was our project. We were reimbursed just for having the plan alone, and that program no longer has, doesn't exist anymore from the Medicaid program. But this is just one example of how health disparity reduction is certainly not at the forefront just yet. So we do need to hold the healthcare industry accountable for improvements across all populations, but it may have unintended consequences of worsening health disparities, as we saw with CMQCC. The logical thing to do, as Marlborough alumni, try to, look at the bigger picture, what's the problem, look back, and do sort of a feasibility matrix, right, of what's feasible with the greatest impact. And you can imagine that sometimes what's easiest to do with the largest impact when you group all patients together might not actually have anything to do with promoting racial justice and racial equity. Sometimes developing interventions to actually improve racial equity take enormous resources and time and may not yield in the global population view large enough improvements when aggregating performance. And so it unfortunately doesn't provide that right incentive model to reduce health disparities and again, sometimes may worsen that. In addition, nearly all measures that are tracked by public and private health plans have something that we call continuous enrollment. It's a sort of a quality measurement term that require that patients remain part of a specific health plan over a time period to be part of that denominator or part of that measure. You can imagine with all the changing health plan coverage, once you lose employment and you're newly enrolled in, for example, one of the covered California plans or with Medi-Cal, that you might not have met that continuous enrollment criteria. So you're not picked up when it comes to sort of health system delivery, quality improvement efforts. And those patients, unfortunately, are the ones that need care the most. And so what we need to be doing is looking at targeting health disparity reduction and re-looking at how we're measuring it, sort of the pros and cons for looking at continuous enrollment as one of the measurement criteria. So I wanted to share just an example of one program that seems to be, some light at the end of the tunnel here when it comes to Medicaid reform. And so they're specifically targeting social determinants of health. This is a program called Whole Person Care, and it's a public and private partnership that brings healthcare and social service agencies, behavioral health all together to create one singular integrated system of care to provide comprehensive services to high-risk patients. It allows for a shared data infrastructure that makes it seamless to provide services, and all agencies share one global budget. This program incentivizes investments in social and behavioral health services and community health workers, and these types of services are typically not reimbursed in the normal health plan coverage schema for community health workers, nor are they easily accessed today. In addition, care coordination extends really past clinical care, supporting patients to have ongoing access to food and housing needs. Also, when you look at eligibility, typically a lot of these programs look at just medically high risk in eligibility requirements, but whole person care does extend past that to look at a more comprehensive approach. So, for example, expecting mothers experiencing stressful life circumstances, i.e. with COVID-19, are eligible for perinatal high-risk support, which includes in-home care, community-based care from a mobile care team, educational support, birth planning, and connected health referrals and services for behavioral health and clinical care providers for their comorbidities that are so important for maternal health outcomes. During COVID-19, Whole Person Care has leveraged their data sharing infrastructure and commitment to improving social determinants of health. So upon enrollment, they have immediately a social determinants of health baseline. And so with that, they were proactively able to reach out to patients that are enrolled in this program so they can effectively look at what their needs are and provide support to patients who need it most. I won't belabor the health disparities related to COVID-19 since Dr. Bath did such a great job at explaining that and explaining really the why and the roots tied to that. And so I'll just move past here to what health systems are doing and how these national and federal agencies are moving forward related to COVID-19 vaccinations. So there are two major advisory bodies providing COVID-19 vaccine distribution recommendations, and they've all included health equity and justice in determining vaccination phasing and distribution. The one on the left, NASEM, has published a formal distribution phasing framework, and ACEP's recommendations for phase A were released a few hours ago for that. And then the phase 1B, 1C, what does phase 2, 3 look like, are still in the proposed state. So though most areas likely will follow ACEP's phasing recommendations, they really have not directly commented on how to promote health equity and justice in vaccine allocation. So what was published earlier today, they just outlined that, well, when you look at the healthcare industry and healthcare workers, it really does range from a broad, it's a broad sort of span of types of workers and from various backgrounds, but that in and of itself isn't really promoting health equity or justice when it comes to actual allocation. And so shown here, NASEM has taken a little bit more, I have to provide a little bit more guidance that I want to share here, that below you can see that equity is a cross-cutting consideration, and they do recommend, using some sort of index to understand a little bit more about the patient. And so one specific index they've recommended is something called the Social Vulnerability Index, and it's applied at the census tract level, so a little bit more specific than zip code, and includes various social determinants of health factors like socioeconomic status. However, NASEM has not recommended to date that we distribute vaccines to people in highly vulnerable communities. Instead, they outline that special efforts should be made to deliver vaccines in populations in highly vulnerable areas where there are disparities in healthcare and pharmacy service access. At UCLA, we are exploring ways to implement a Los Angeles specific index that was co-developed at the UCLA School of Public Health. And we're also exploring ways to further promote health equity when it comes to distribution logistics of how we get the vaccine to patients who need it most that may not be able to take off 2 days, travel for their first dose and second booster, 3 weeks after that. Unfortunately, initial surveys have shown that there are disparities in vaccine acceptance rates, and a community outreach, public health awareness will be so key in ensuring that even with this vaccine rollout, even if we do whatever we can to promote health equity, that if we don't focus on vaccine acceptance, sort of education and awareness campaign, that these health disparities that Dr. Bath had outlined related to COVID-19 are not even further perpetuated with this COVID vaccine rollout and onwards. And so what can we do to advance racial justice and eliminate health disparities in public health and in the healthcare delivery realm? So my recommendation is really to start with just general shared goals, goal alignment. Yes, cities like LA can declare that systemic racism is a public health crisis, but we really, again, need to have an all hands, all sector commitment, have the payers involved, have all the social services, healthcare providers, so that we're looking at the grander picture than just, the attributed lives that may, for example, afford to see a UCLA health provider or other healthcare providers and have regular access to that. So multiple groups are starting to think about how to measure disparity reduction, certainly in their own siloed environments, but we need to have a global shared accountability and how we target that, and in that targeted measurement, how will we, the global we, measure success as a city, state, and nation when it comes to eliminating health disparities? How will we share that data within our own organizations and outwards? And efforts to address health disparities also require cross-sector approaches beyond healthcare to affect the broader social and economic factors determining health. And we need to make sure that policies and health plan reimbursement structures, other reimbursement structures incentivize that comprehensive approach, much like whole person care and Medicaid reform in Los Angeles have taken. Lastly, public awareness and engagement around all these issues are absolutely critical. We need to keep the conversation going. We need to take action today. And I sincerely hope that we all take action in whatever roles we're in now and in the future to advance racial justice and health equity now and beyond. And thank you all for your attention and time this evening. It's been a pleasure speaking with you all. And I think, Megan, we're going to open it up for questions.
Yeah, thank you so much to both of you. That was such an incredible amount of information that you shared and were able to impart to all of us in such a quick amount of time. So thank you. I have a couple questions that I can kick it off with, but if you do have questions, please feel free to put them in the Q&A box and we'll try and get to as many of those as we can. But the first question I wanted to ask was, it seems like to kind of get this to work, to solve this inequity issue is really requires a lot of teamwork and collaboration. I think, as you said, Lily, a couple times across the healthcare sector. So for example, someone on Lily's team needs to be communicating your findings or initiatives with doctors who need to be sharing what they're seeing on a daily basis with their patients, et cetera, et cetera. And I'm sure I'm oversimplifying that quite a bit, but I'm wondering for each of you what that sort of collaboration looks like for you kind of on a day-to-day in your work.
Sure. So just within UCLA and with our local providers, all the residents, nursing students, absolutely there's been more conversation today than there ever has been before, which has been tremendous to see. We have, sort of an action plan, an equity, diversity, inclusion action plan with it for our organization that spans not just how we promote from within, how we recruit and retain, staff and residents, et cetera, and then also when we think about just patient access, how do we make sure that those that need care most can see our providers and we can extend our reach there. So I think just a lot of listening, I think sharing our own experiences from our team, it's more our data and kind of what we're hearing from health plans, what resources they have to offer, and vice versa. I think from when we meet with a lot of health plans every day, all the bigger commercial plans, regulatory agencies, and they are committed. I think now when it comes to what actions will be taken we will see from those broader health plans and community agencies. But I would say I think there's a more willingness to learn and collaborate, and that we do have that shared goal. I think that's been it's resonated with me that I think we're all aligned in where we need to head in the future.
Just to add to that, on the sort of physician side, I mean, one of the biggest and most important things is to really mitigate bias. So everyone has, bias, and it's how we sort of navigate the world, right? Implicit bias, but really training physicians and healthcare providers to recognize their implicit biases and their unconscious biases and try to correct them. And so that requires a lot of reflective, spaces, trainings. One of the things we're about to initiate in the Department of Psychiatry is to actually have a series of book clubs for both physicians in training as well as faculty, using Layla Saad's book, Me and White Supremacy. Also, the School of Medicine at UCLA has a common book, and it's reading Ibram Kendi's How to Be an Anti-Racist, because a lot of, going to 3 hours of training or a couple of days of training is not sufficient. It's necessary, but not sufficient. So sort of layering learning in different modalities, that shoulder to shoulder, and just really being, willing to have dialogue about some of these concepts.
Thank you. Eraka, this is sort of specifically directed to you. I know so much of this has been COVID-19 focused, but obviously it's top of mind for all of us these days. So Eraka, I was wondering if you can speak to the impacts on people's mental health that this pandemic is having, and perhaps what you and your colleagues are thinking of or worried about in the long term, the effects on mental health that this will have for communities.
Yes, I mean, there are definite impacts on mental health, I would say across race, class, and I mean, they're significant, right? So people are, humans are social animals, not being able to, the different ways in which we have to connect. And, being someone who is privileged and has a house and great internet, I can, house party, Zoom all the time. But imagine if those things weren't available to you, right? Or if it wasn't so easy to just Instacart, whatever random groceries you want. And so those things really are, impacting. And what we're seeing, I think, is the sort of economic vulnerability adding different layers of stress, right, and anxiety. So families who have food insecurity, which we know many more American households are experiencing that, and those things are all adding to the mental health burden. And I think one of the challenges is for many youth in particular, schools are a great source of accessing mental health supports and services. And so that's one thing I think, just re-envisioning how that needs to look, during the pandemic, it's an ongoing challenge.
Thank you. Lily, I worry this might be redundant, but I think I'm going to ask it anyway. How, since the onset of the pandemic, how has your work with your team changed? Or how, I mean, obviously, again, it's top of mind for everybody, but how has that impacted the ways in which you conduct your work?
Sure. Yeah, I think we've needed to be much more proactive today than ever before. So, for example, deferral of care. What the first thing we did, as we saw with the safer at home order, once it was, sort of more open and healthcare visits to see your doctor, it really took a long time for routine care to kick back in. So we essentially just looked at all of our data, ran it across the CDC guidelines and criteria for patients with multiple underlying health conditions that might have severe illness from COVID-19 if they were to contract it. We did proactive outreach to make sure that patients that might have dementia, that may not have social support, are connected back with the health system. If they weren't able to, figure out telehealth is all new, and if they don't have internet and all of that, working with a contracted vendor to make sure that they delivered the sort of equipment and everything in the home, so that they were all equipped to see their provider and they weren't deferring needed care. So I think there's been a shift from in my role now, we look at how to make healthcare more affordable from a healthcare utilization, total cost of care perspective. This was the reverse. We know that there was a lot of health deferrals and we're trying to mitigate the longer term health outcomes from that health deferral that's happening today. So that's one. I think just when it comes to all of our quality measures, just how to get patients for in-home screening, that also has shifted. So we're doing more in-home testing for colon cancer screening, for example. We are mailing a lot of things to patients' homes, like fit kits for colon cancer screening. So leveraging sort of more in-home care as much as we can outside of the virtual visits and telehealth.
So a lot of changes that you, I'm sure, had to make very, very quickly.
Yes, and still now, I mean, it's an active pandemic, and I think we're quick to shift and quick to pivot as need be.
That's great. I saw a question come in. I think, Eraka, are you going to take this one?
Sure, and I would be curious to hear, I think both Lily and I can add comments around, the question is around a problematic history of medical experimentation and racist pseudoscience and impact skepticism in medical care and treatment in the Black community, and I'd say in communities of color in general. And that with the rollout of vaccines being, targeted towards Black people as the most vulnerable populations impacted by COVID. I mean, this is such a important topic. I mean, one of the challenges I think across health is this concept of weird science. So, and weird stands for Western educated, industrialized, rich democracies. And there was a paper by a scholar named Henrich in 2010 that found that the majority, over 90% of social science studies were on quote unquote weird people, so 90% on less than 12% of the weird population, right? And so we don't have enough data, and historically it's been a problem, both engaging BIPOC, Black, Indigenous, people of color communities in research protocols. And so we do need to do it. And there's a reason why there's so much medical mistrust. And so, as Black people, we need to be getting the vaccine, what I mean? But historically, it makes sense that there's a lot of fear and mistrust. And as I shared in the slide deck, so many people, because of provider bias, get turned away from treatment. And so I think that this is an ongoing challenge. Different centers across the country are trying to have more culturally humble, racially attuned engagement practices to really partner with BIPOC communities to enlist them in research and other activities. It's really needed to sort of course correct weird science.
I think with that, with our vaccine rollout, that's going to be key of how do we, bridge that gap, and build that trust back. Because with otherwise, I think again, just the quickest and easiest will be the route that most delivery systems take, and not wanting to bridge that gap when it comes to the trust in the medical community in these underrepresented communities.
Thank you. So we are coming close to the top of the hour, so I will just close with this question. What's next? What can we as sort of regular people be on the lookout for? How can we kind of ensure that we are we are helping to close this gap in some way? I guess, what would you say, how would you tell us to kind of move forward?
Eraka, I'll defer to you on this one.
Well, I think Evelyn had asked a question in the chat that I answered, but I think it's apropos of this question. And it's really, like, what can we do? What's next? And I think it's really about considering your own positionality and what spheres of interest are in spheres of influence and interest are available to you to implement anti-racist practice. And your spheres of influence are large. It's your family, it's your parenting, if you're caregiving, it's your friends, it's your employment, it's where you volunteer, it's where you buy, where you go to the movies. I mean, all those things really have ways to impact. And I would read and make sure that you are not ahistorical and that you're anchored in history, and just recognize the importance of representation and representational narratives.
Great. Well, thank you both for spending so much time with us this evening. This was I certainly learned a lot. I hope everyone here did as well. I'm just so appreciative to both of you for sharing this time with us. And I, of course, also want to thank all our fellow alumni for joining us. Thank you for taking the time to be here and participate. This was actually the final installment of our sort of first round of Aiming High speakers, and we are getting ready to share the next round of exciting speakers with you. So keep an eye on your inbox within the coming weeks for that announcement. This program, we really started it as a way to stay connected through this strange time of new virtual work from home lifestyle. And I just want to say how grateful I am to all of the speakers, certainly including Eraka and Lily this evening, and all of our attendees for helping to get this series going with a bit of momentum. So like I said, keep your eye on your inbox for the announcement of the next speakers for the first months of 2021. We've almost made it to the new year. And I hope we'll see you there. And please, of course, tell all of your alumni friends and classmates to join us too. But finally, I just want to say one last massive thank you to Eraka and Lily for joining us. Have a great evening, everyone, and we will see you in 2021.
Thanks, everyone.
Thanks, everyone, and thanks, Megan.
Stay safe. Bye.